name is Nicci. I'm so pleased to be here. I'm so proud to say it's my 43rd year of being a nurse in healthcare. And I think we're going to switch the tables a little bit. We're going to be talking about what do we do about the vulnerable, the underserved, those people who may not necessarily be tagged into this tremendous thing we're doing in healthcare. And that's technology that can help with inefficiencies. What about those people that are underserved, vulnerable, and what do we do to make sure that they're not lost in this shuffle of this advancement in healthcare? So I am so proud to be on this panel with some very experienced people. We're going to talk to you a little bit about what do we need to think about when we move the needle a little bit in healthcare technology. So I'm going to start with Heather down at the end. Can you tell us, and I'm going to ask each one of the panelists to introduce themselves a bit so that they can tell you what they represent in the healthcare arena. But I also want to talk to them a little bit about their definition of tech equity and a tech equity story.
Very good. Heather Cox, I'm pleased to be here today. I am with Zelis, and at Zelis we talk about kind of price, pay, and power across the payer, provider, and member landscape. I'm here today in this seat as my role representing the empowerment of members. So Techquity, really important piece of, and it's a great new word, frankly, but I think we all get it, but the reality is the advancements in technology are wonderful, but technology for technology's sake is a risky proposition. And while it can advance us on so many fronts, at the same time, it could actually lead to further disparity, further inequality in healthcare. And we've got to make sure that we really take effort to design appropriately. I've heard the prior panels really talking about human-centered design. In its core, it's critical, and it's very important. I would argue you got design, you've got the human in the middle when you're starting to talk about the application of AI in healthcare. But you also have the ethics of AI, which I just heard on the prior panel as well, what are the principles by which you will operate at all times, and making sure that it's always inclusive and equitable. So really exciting times, but also very challenging. So we've got a lot to balance as we think about technology. I think one of my favorite stories where you think about where we need to go, we did deep ethnographic research in a prior life of mine out in the field in members' homes and trying to really understand what are the barriers to access. And we happened to be in more rural areas, so there were a couple of barriers. One, this particular member has advanced diabetes. And while they had refrigerator and power, which is great, you open their refrigerator and there's no food. So think about someone who has the medication they need, but if you don't have any food and it actually can consume properly, it becomes a real challenge. And so we bring that back in, and it suddenly becomes an opportunity to change the benefit schema for the payer themselves. And so making sure that we're offering different kinds of benefits in the MA space, which is really exciting. And so that's where that design can come all the way back in and really help you develop new products and services that can be super relevant. I think I'll pause there and let my colleagues.
Yeah. Maura, would you like to go next?
Yeah, absolutely. It's great to be here. I was here last year. I'm the founder of a company called Oscar Health. It's a health insurance company. I almost said startup, which it was and still is in my heart, I would say. But it's a relatively big company now. I started about 12 years ago. We launched the company. I have a background in computer science, specifically so we can compete in the individual markets, because we thought the Affordable Care Act markets, individual markets, is both a place where you can get directly to the end consumer, so you can convince people more with a good product experience to sign up for you as Oscar, as the health insurance company. But you're also sort of uncovering a new segment of the population in the US, namely the folks who previously didn't have insurance and who we can now go help get coverage, get access to the healthcare system, and so on. And so it was a very nice combination of both, I think, generally sort of a noble idea, but also a really good business. And we're trying to make it a better and better business for us, given that we're on this path from startup to real company in a sense. But I think we're well on the way there. The company is now about $6.5 billion in revenues this year. Important sort of like break-even points on the business this year. Profitability in the insurance business next year, probably in the overall insurance company, and the second biggest player in the ACA marketplace now nationwide. My story, I think, is, well, let me actually first say what I think my hope for Techquity really is. And it is very, very simply that we can give more affordable access to more people. That's how I break it down to the extreme simple sort of driver. What can an insurance company really do in the healthcare markets? It can't deliver care entirely itself. You know, we have a medical group and we do virtual primary care, virtual urgent care and whatever, but still, we pay for stuff. We don't deliver the vast majority of care ourselves. So given that we pay for stuff, it should be our job to make things more affordable. And I think there is a real opportunity through more technology to give that to more folks, more people. Speaking of virtual urgent care or virtual primary care, we, for example, see that if members become attributed as a member to an Oscar virtual primary care physician, which they can do as part of our plan, some plan designs we have, then the number of communications we have with them goes from 4 a month to 8 a month or something like that, which is a form of access, right? You have more freedom of movement, more freedom of conversation with now a caregiver in a way you probably couldn't afford before that. So that's a good example for Techquity to me. My story would be one where, again, I think we combine the business with equity, which is, I used to do this thing where, still do it post-pandemic again now, where I would go before open enrollment starts in the ACA and would meet with brokers and in various markets we're launching into. And so I was in Miami-Dade, this is probably about 3-4 years ago or so, before Oscar first launched in that market. We had a room full of brokers, and what I would usually do in these situations, I would demo the mobile app and the websites and say, this is the Oscar experience, here's why I should sign up your people into it and whatever. And there was 3 people in that room who kept cheering loudly and singing or whatever and standing up and so on. And I thought, who the hell are these guys? And so it turns out it was the 3 brokers who represent the Haitian community in Miami-Dade, in the ACA, which is one of these examples for a very tight-knit community. In the ACA in Dade County is probably about 40,000 members, so it's a decent chunk of the ACA down there. They have a set of physicians who all these folks go to. They have a small number of brokers who sell access to these members in the ACA. And in a weird way, that's sort of Techquity in some sense, right? It took some real on-the-ground work to convince those folks that we have a better experience. We're building a better one for them. And there's a lot of work we were able to do over the years with them, and I think we still have a big chunk of that population down there. So good for the business, and I think good for access and good for equity as well.
Awesome. Sachin, it's your story.
Gosh, I got tough acts to follow. So I'm the CIO of the U.S. Commercial Division at Cigna, as well as a lead on data and analytics engineering. When I think about tech equity, I think about how, from a technology perspective, and I think about it as a wrapper of people, process, and tools, can deliver on enhancing and delivering on social determinants of health, and bending that cost curve and the costliness and the lack of accessibility that's in the marketplace across so many segments. And so when I think about our people and think about how we can change the dialogue, it starts with our people. It starts with diverse talent. The very data scientists, the engineers, those that populate our base of employees and contractors, for that matter, that deliver our software, need to be thinking and come from the segments we serve. The second thing I mentioned was process, and that's really strong governance and controls when we're creating the models on which our provider community and others are basing their potential actions and the advice that we're giving. Having controls around those models and ensuring that we have the right governance. And so that's important. And then finally, the tools from an outreach perspective, and those should be familiar to all of us in terms of digital engagement and the other channels, but I think about accessibility as well. Different segments of our population engage differently, and it can be anywhere from text messaging and don't bother me to some folks still want to get the mail. And so how do we navigate that from an accessibility perspective, as well as kind of from a digital, I'm thinking about visually impaired and other populations that we need to make sure our technology serves. So that's the wrapper that we think about when it comes to how we serve and think about social determinants of health. And from a story perspective, something that's I think similar to Mario, the story you told in terms of local. We're in Ohio, and we use a tool called the Neighborhood Health Tool. I know not a very fancy name. When I heard about it, I was kind of like, could we have come up with something more creative? It's kind of literal. And so the neighborhood health tool is based on a lot of really cool technology, geospatial. It gets down to a zip code level and a very micro local level. And one of the things that resonated with not just the broker community, but others in the population, and what resonated was that we were able to channel and advise patients around not just normal sort of channels of care to a provider or whatnot, but to partner organizations that were nonprofit that would, again, serve that accessibility quotient that we so often miss. People trust perhaps neighborhood service providers that might be down non-traditional paths, but otherwise deliver the outcomes that our patients need. And so connecting those was a really cool experience, and we got amazing feedback from that deployment of the tool for the first time.
Awesome. Thank you. Heather, talk a little bit to me about, you've heard a lot from the other panelists about putting the patient in the center and accessibility. And so what do you think about now after you've spent a whole day thinking about how would you design and implement things differently?
I think the key is always put that end user at the center, right? That's so critical. Even if you're a B2B business model, making sure you understand who they are trying to serve and that you, in essence, go all the way down into market and bring it back into your product design. I think it's critical. But I also think about accessibility, how do you ensure great network design so that you can actually get the people to the providers and the care teams that they need? Then how do you think about leveraging the human touch combined with the digital elements of, you could use the digital tools now to go find that right provider at the right cost and incent them, as we try to do, and then reward people for actually getting lower cost of care with higher quality providers. And again, putting that back into the analytics that we help you then redesign your networks the next year. How do we consistently think about access and the intersection of human and digital? Because I think in healthcare in particular, this notion that you can do all digital or all human, we've got to really rethink that paradigm. So the digital to physical interactions, physical back in very elegant ways, is where the huge unlock and opportunity is. And when we think about it, it's how do we start to take all the data points that we're generating from all these interactions and turn that into real insights for our clients so that you can actually have real value add services with the data and the analytics. And this is where the AI can come in and be really powerful. But we've got to take the baby steps. Test and learn is really important in our world. So design, test and learn, and then figure out how to find opportunities to scale. But leveraging technology all the time.
Mario, how would you answer that? I mean, you've heard a lot from our other presenters about how we've got to start reforming our thinking as we deliver healthcare.
I would say two parts of this answer. One is anthropological research, and then the second one is test and learn. Anthropological research is what I always like to jokingly call when you really try to get under the hood of how somebody experiences and uses healthcare. And I think the healthcare system, in some sense, does too little of that. And I would include sometimes Oscar in that too. We sort of think that we can convince people to just use their entire healthcare journey, move it all into our tools. That's the goal for everybody. Or we ignore it altogether, what the journey is. But that's just not how healthcare works. One of the reasons why I think the big technology companies have not fared very well in digitizing the healthcare system from their point of view is because they generally exist in areas where they can control end-to-end journeys. And in healthcare, nobody can control an end-to-end journey. And so anthropological research very simply means you take an individual and you follow that person around during the day, almost. You look exactly when do they come to the, whatever in this case, Oscar mobile app, when do they look at the scheduling system of a primary care practice, when do they, when is something bubbling on their mind or whatever else, and you bake that into product design, to end-to-end journey design. That's much easier said than done, but I think it's generally a good mindset to have, because it is very true and very clear that there are big differences. I think Sachin, you said the same thing, in how different segments and certainly individuals of the population are using healthcare. I mean, not to just make it a simplistic statement, but when we look at our Spanish-speaking population, I think about 30% of our ID cards when they go out are going out in Spanish. So we have a very big chunk of Hispanics folks on the plan. When we look at that population, even if you control for all other variables, they go to the doctor less, they go to ER and urgent care less, but they have higher net promoter scores. And it's a weird sort of disconnect. I mean, we're very happy they have high NPSs, don't get me wrong on that one, but if we can't understand why, because they're not even utilizing healthcare, we're not even helping them in this way that we would like to think the high NPS comes from, then why is it higher? That, I think, sort of calls for this kind of getting deeper under the covers there and understanding where that comes from. So that's one part of the answer. But the other one is, in the end, nobody has any idea what works and what doesn't, from just doing research and from just sitting in the ivory tower. And you have to have a very rapid cycle of testing and just checking out what works and what doesn't. And so we built a tool internally called Campaign Builder, which lets us very easily put together new tests and new campaigns, and everything we do runs through that. And you can then realize that, and again, at the risk of sounding too simplistic, but if you have somebody who has a chronic condition, they don't respond to messaging of empathy as much as to messaging of convenience, because they want, they sort of like know how to manage their condition. They just want to know, can we help them cut out time in their daily schedule of managing the condition? But folks who are generally healthy, might have something going on, they're a bit more amenable to messages of empathy and getting them engaged that way. And so those are not things you can necessarily intuitively discern. You just need to test them and see what works and move on when something doesn't work. So part of the toolkits.
Sachin.
Wow, as I said, it's tough going after these.
I'm going to let you go first next time.
Thank you. What I'd say is, building upon a few of the answers, I'll start with the test and learn. And seeing my colleague Chris out there, Mario, they have much cooler names. We have a very similar application called literally the Customer Data Platform. That messages and tests, that tests and learns messaging, and it's to that nuance. I think that's something we're all sharing. It's that, again, it's not just about the populations in the various segments. There are even subpopulations within them in terms of how you can communicate and what resonates, and will drive them to take insights that we may deliver. I think the other aspect is thinking about the patient-centric model. Is making sure we understand that ecosystem. Going back to the partnership model and the theme that I'd mentioned earlier, providers are a big part of the journey. Pharmacists are a big part of the journey. They continue to be, I think, the most trusted healthcare advisor in the ecosystem. So those connections, that we understand them, that we bring those insights in, and we understand how a patient needs to be communicated to in the most effective manner to drive the best health outcome. And so thinking backwards from that and thinking about all those variables, it's somewhat daunting. It's not easy, but the other aspect that I was sort of bemoaning this to the team backstage was, gosh, to get something done, it feels like I just need 4 or 5 really good engineers to put hands on keyboard and just drive and test something. At times that's not always possible, but it is the approach that probably gets us the greatest value and gets us to answering to this segment's needs, the very segment's needs in the fastest way possible.
Yeah. So I'm going to pose a question. I'm going to let you go first this time. So you're going to have to talk again. What if you had a whole bunch of people in a room and you said to them, we got to slow down a bit. We really have to understand the patient journey. What are you going to do to convince them? Because I think we talked backstage about this a bit. I don't want to touch my workflow. I already know what's going on. Clinicians can't tell me anything. How are we going to get people to start saying, you know what, probably the best partnership is engineers and clinicians?
Probably,
I would pose.
Right?
Be provocative, but I'm going to propose that. So
sure can't start with Heather first?
No, we're going to start with you.
Okay. I'm kidding. I do think we, from an intent perspective, we all need to assume positive intent from the value chain. And I mean that, whether it's payer, providers, clinicians, you name it, in terms of all the players in employers. It's one group we haven't talked about that are a critical part of the ecosystem, given that they often stand behind payers. When we think about the ecosystem as a whole, assuming positive intent and then getting into a room like that is really being patient-centric. And I know there's better terms in this, design thinking and some, just sort of taking that whiteboard and thinking through, what does that patient journey look like? What are all the touch points? And then looking at, this is something we haven't talked about yet either, is just what's the greatest value And there are multiple value drivers in the ecosystem. But from a patient's perspective, what's the greatest value we can achieve from an outcome, and working backwards from that? And I do think your hypothesis is probably correct. What I've seen at our firm is that putting clinicians with a small group of engineers as a product owner, let's say, really does drive excellent outcomes and allows us to test and learn quickly. However, I'm amenable to learn about other models as well that allows that value. And there's nothing that's stopping us from doing things in parallel that impact the patient in different parts of their journey, because it'd be very difficult to hit a one-size-fits-all solution.
Great answer. Thank you. Heather, do you want to go next?
Sure. I think there's a couple of things I would talk about. I think there is the notion of having the right diversity literally around the table to actually think about, what are we doing? How are we doing it? Have we spent enough time with the end user? Now bring it back in. Let's start to design. But then when you start to think about the application of the models that I was referring to earlier, the digital is wonderful, and there's a lot you can do. It throws off a lot of exhaust, and a lot of times we just look at the data itself and wonder, think we understand the activity. But to your point, when you actually really start to study, can you get to better and better answers, more efficacy in the product itself? And I think the whole notion of having real diversity around the table and notion of why does inclusion matter when you're building models, when you're building product, is really critical. I think the enabler, I would argue, is so you get to that high we were talking about personalization earlier. And to your point, that single, individual point of care, building the technology appropriately, right? Obfuscating your back ends, leveraging things like APIs, really understanding which ones do you turn on when and for whom and why, I think is just one of those big opportunities for us to take technology, apply it to personalization, and then put the data and analytics on top. I'll just keep going in circles, but I think it's the combination of focus on inclusion and build appropriately.
Mario, how about you?
Yeah, the only aspect I would add to this is, and great thoughts from both of us, from all of us here, but is the money. In the end, I think if you can't wrap, new technologies and new ways of delivering care or insurance, whatever, into some kind of business model, it is just not gonna. It's gonna get squeezed out by the healthcare system. And one of the observations I noticed recently that kind of blows my mind is the fact that when you look at all claims lines across the country, and Fair Health is one of the ones that track this stuff, then telemedicine as percent of all claims lines has been going down since the peaks of the pandemic. It's still going down. And I think when there used to be something like half behavioral health, half non-behavioral health among all telemedicine lines, now I think it's down to something like 3/4 behavioral health and only 1/4, everything else basically in telemedicine. And I think it's down to less than 4% of claims lines or so are now still telemedicine claims. And why is that? Well, because the existing healthcare system is getting paid too little for telemedicine, at least in their view, and not in my view, right? If we don't use telemedicine as an opportunity for getting healthcare costs down, then we're missing a massive opportunity for sure, right? But that's how health systems, for example, think, and I even understand it. If you have, all the fixed costs and everything else, and the ERs and so on to pay for, it's not great to shift more of your volume towards telemedicine, which will have a lower reimbursement rate. That's just the way it is. At the same time, just in the last 3 weeks, look at all these retailers who've been announcing telemedicine direct-to-consumer platforms, right? Walgreens, I think, is doing it, and Walmart, and whoever I'm forgetting now, Kroger's, whatever, right? All these guys come out. Again, business, that's where the money flows. These guys think they have an upsell opportunity, cross-sell opportunity there. And I think when we talk about technology and now AI as well, and the application of generative AI and so on, if we don't find ways to somehow shift more of the care delivery towards risk and towards where care delivery players can make more money, the more clever technologies to deploy to get costs down, I think this is all not going to work again. You're going to not deploy. What's going to happen is, I remember a few years ago being at some panel, and there was a guy who is the chief medical officer of some big Silicon Valley tech company, and the person was saying, I love telemedicine. I can now call my doctor 3 times a day or whatever. And I'm like, you're exactly the wrong person to use telemedicine. That's not deflationary for the system. That's inflationary for the wrong people, kind of. I mean, he's a nice person, you know, but already has enough healthcare, you know, and so, and I think that's a real issue. And so, you know, more shift to ideally towards value-based. That's almost become a bit of a how do you call it? Like value-based is it's not the same ring anymore as it used to have, you know, but more of a way of sharing between payer and provider. The outcomes of deploying these technologies is a really important thing to get right.
Right. So she talk a little bit about AI. I mean, you're really an advocate for that. You really are an advocate for the workflow and to get it right. And how do you think that's going to help us?
I think from, working from outcomes, it's going to help us accelerate, in some cases, drive affordability, which should and must reach the populations that we're talking about that Techquity could serve. I do think that putting my data hat back on, wear two hats, governance around that data and the security of that data is going to be incredibly important. At the end of the day, deploying AI tools, whether it be machine learning, the current ones, machine learning and others that drive insights, and then in the future state, generative AI, trust is going to be a huge factor, especially in some of the populations across socioeconomic areas. And building that trust is going to entail making sure that we are transparent on how data is used, what data is used, how it's governed, how we test for bias, all the right things that I think we do today and that we're cognizant of. And that is going to be critical as we move forward, regardless of whether we're using AI to touch operations, whether it's to build more custom networks for individuals, to lower that cost of care, improve outcomes. Trust is going to be underlying it, and it's going to be the data that does it. So, and then finally, the other aspect near and dear to my heart is around data governance and making sure that outside of the control and trust that we're building, how we consume it is normalized. I know across Cigna, that's something that we are very focused on, and I suspect that's true across the industry as well.
And speak a little bit more too about Cigna doing the neighborhood. You got out there and you taught people, or you informed people that the trust was really high.
Yeah.
Can you speak a little bit to that?
Yeah, and the focus there was that it becomes more of a self-service tool across the broker community, across patients, that you have the ability to see and sort of play around with yourself and touch and feel where those providers are based on the insights that are being driven on your behalf. So the informatics around that are critical, and it's something we're going to continue investing in.
Awesome. Mario, talk a little bit about that too. How do you think AI is going to help us with this whole process of getting out to those vulnerable populations that maybe don't have the access? I mean, you and I have talked about that a bit. You know, how are you going to do that? How are you going to use AI to do that?
Many ways. I think one certainly is extremely simple, which is what we are doing internally mostly right now is we're plugging LLMs into all kinds of administrative workflows. I think that's where they can, in some sense, you have the least downsides, right? There's no direct to consumer output there. It just kind of makes some process flow better. But it's incredibly powerful there. We are about to replace the manual transcribing that care guides do in customer service conversations just entirely with GPT-4, because we've been having the same QA people rate the care guide written call summaries, the notes that they take during a call, versus what happens when the AI does it, in essentially the same quality. In fact, even they have sometimes more details in it where you realize, okay, this problem was really a provider data problem, even though it showed up as a PCP attribution issue in the call care guides notes, whatever. So, and the reason I think that is actually an important place to apply AI is because any cost we can take out on the administrative sides is a good thing for the overall healthcare system, for the affordability of healthcare. We consistently see that people who have low net promoter scores inside of Oscar, we screwed something up. There was a UM that was late, or in their minds late, or there was a claim that didn't get paid in the first go around, and those kind of things. And so all of these processes, I think, are still very ripe for the taking of more application of generative AI. The other two opportunities are more personalization. We talked about this already, right? How do you talk to whom, over which channel? Text message works better than email in different demographics in parts of the country. WhatsApp works well in the southern part of the United States, certainly among the immigrant population that's more popular. How do you personalize more? And then the other one is really how do you increase this frequency of communication. I mentioned the kind of Oscar virtual PCP thing there, where just number of times we talk to a member goes up a lot if we have a more direct care delivery relationship with the member. I think the way we deploy it right now internally, maybe one brief word in organization is, I formed this AI pods of a number of people who are just the sort of core brain trust for how to deploy language models everywhere. And all the work that they do is to study this stuff and then build some prototypes, but do that with the distributed teams. So the engineering team that works on whatever, customer service or claims, whatever, they then kind of work with that pods to see what they can do in terms of the tools there. And then we publish all these results. So people can go to hioscar.ai, and we have what we call our continuous hackathon, where we just said, the way you got to run these things is in constant trial and error with these small teams that try something different. And when we find something out, we try to put it out there and talk about it very quickly publicly as well. So you're welcome to check that out. And I myself do a lot in it as well. I have one I'm writing this afternoon still, hopefully to get out there. I demoted myself last year. I used to be the founder and CEO. I demoted myself to now the CTO, the Chief Technology, no offense, by the way, Sachin, to the CTO, where I can then run engineering, product, and data science, because we hired a guy named Mark Bertolini, who was in a prior life the Aetna CEO, and who's a fantastic person to, I think, run the overall company, partly so I can spend more time where I think I can do it better, which is this kind of stuff, at a time when a lot is happening in this space, for sure.
It's nice to get out there. Heather, how about that AI? How is it going to hinder or help?
So I'm going to take a slightly different angle, because I completely agree with what you both have talked about. And I think, Sachin, I really appreciate you bringing up the least sexy topic on the planet, data governance, but without it, this is never going to work. So this AI thing will get out of control very quickly if we don't care deeply about the state of our data, how it is organized, how it's secured, how it's managed, how it's consumed. And so just double emphasis on it. And I love your examples of how you're being able to take administrative cost out. I do think AI is an unlock, as we talked about earlier, to so much of this techquity. And in particular, when you talk about applying natural language processing to social determinants of health, like anything that's not an ICD code suddenly becomes available and consumable within models. It's really exciting. I worry. I'm greatly worried in that we're also going to use AI that's not explainable, and we can't go back and understand how it came up with the result. So back to the governance piece. I also worry that we're going to use it to say no. In healthcare, we love saying no. And we like to deny the claim. We like to tell you, you can't have that care. We want to tell you, you're done with your care on day 14. Even though you're an individual, you might need day 24. And if we start saying no, leveraging this technology, it's going to get locked down, and we're not going to be able to apply it in healthcare. So this is a place where we've got to take this very seriously. This is not about making the business more profitable. It's about finding the places to improve processes and take down cost of care, but not say no. So it's a weird balance, but we're really going to have to figure it out, because otherwise we're going to find the White House just issued notice the other day. They're coming after, it's healthcare. You cannot say no. And I think it's going to be important for us to really focus on this. And again, on the prior panel, this whole notion of if the industry could just get some basic principles, some basic guidelines that we're all going to operate by, I think we could serve ourselves well.
Yeah, thank you. So we got about 4 minutes, so we're going to do a lightning round. So you ready? Okay, I'm going to ask you a question. So I'm a nurse. I work in an indigent population in downtown Denver, and they don't have access to health care. Tell me what you're going to do about making it more equitable for me. For me as a nurse, trying to provide care to my patient, and just give me a short line message that says, I'm going to try to do this for you. I'm going to get to know you. So, anybody want to go first?
I vote Mario.
He's a really good coder, so I'm not.
Okay.
I know this is a tough one.
Yeah, it's a very tough one. I'd be tempted to say, just to swing wildly for the fences, to create a plan design very individually around you, and to somehow bundle into the plan design all the social functions you would need as part of serving this population well, and and maybe even convincing the governments, the state, because it's a state-based stuff, to give you a risk adjustment formula that operates over 5 years, not 1 year. To sort of like say, all right, Nicci will have 5 years to show that if she bundles in nutrition and some transportation and some
And I
other
can get
things in
some
this
phones
plan.
for these people, and I can have access at the church.
Yeah,
and,
exactly
okay.
right. That's
There you go.
that there's a whole bunch of money. You get the whole premium to play with, as opposed to only whatever reimbursement you otherwise get for the doctors. You can get into the network or something like that, and have that be very bespoke plan design that you directly control. I mean, that would be what
Awesome.
to do in.
Awesome. I love it.
I think in the short term, think of things in short, medium, long term. In terms of immediate relief, I think I agree with everything Mario just said in terms of how to get a population set up and how to help you as a provider. I think in the short term, what I think about is those resources that we have on the ground, that we have partnerships with, and the provider portal that we can deliver that would look at through tools like that neighborhood health tool that would provide the insights that would allow you to analyze the population and then look around for those nonprofits and other sources that are available in the community to get the population some help immediately. And I do think there's a factor where the government does play a role. I think they've got services set up along with nonprofits. And I do think in the future state, everything Mario said, that in terms of delivering healthcare is something that is achievable.
Right. And I love promoting that neighborhood thing. Bring it to me into the church. Let me be able to manage and risk stratify my patients. Awesome. Heather?
I'm going to focus on tools that allow you to engage human to human, but yet get the value of what the technology can bring. So ambient listening, so you can focus on your patient and allow you to ask the right questions, gather the right information, have it translated, populated into the EHR, take the administrative burden off you so you can have hands-on patient.
I love it. And be able to have me deliver back a care plan for my diabetic patient who has no electricity.
Yep.
Or my, so thank you. Any last closing remarks? I appreciate you guys so much. It's been so exciting to be with you. I feel like our healthcare has some hope.
Thanks.
Any closing remarks?
I'd say the theme that really popped here is trust is going to be incredibly important when it comes to the various segments of the population that aren't the ones that Mario was talking about, the person who's just going to hit their doctor 3 times. The populations that we serve don't have that time. Maybe don't even understand they have that ability or capability. Reaching them and building trust is going to be important.
I love it. Closing remarks?
Yeah, I mean, the only thing, it's absolutely true. The thing I always say that when it comes to AI, because we mentioned that as well, very important to just play with it yourself. Sign up for Midjourney, it's a graphics engine, and for obviously ChatGPT and so on. Pay for the ChatGPT Plus thing, you get more additional benefits from that, and play with it. This morning I was trying to get it to trip it up by giving it a patient description and then say this patient lives in the Bronx versus lives in Palo Alto, and see if it comes back with a different diagnosis and stuff like, and even saying like this patient likes this food versus that foods, and just sort of like trick it into thinking that's a certain demographic with certain stereotypical patterns of issues and so on. And yeah, it still has those issues, and so you need to see that, I think, live, and don't just hear this from your engineers or whatever else. That gives you a whole different appreciation for the power of this technology and then the pitfalls of it at the same time.
Yeah.
Or overtime, but I look at the profile of the folks that attend this particular conference, and if we could all sign up for making Techquity a priority, the world will be a much better place in healthcare. So,
Thank you. Thank you all. Appreciate your time.